Welcome to the Resilient Performance Podcast. I'm your host, Doug Kachijan, and today I'm joined by Nicole Surdyka. Nicole is the owner of Surdyka Physical Therapy and Performance, a concierge-style physical therapy and sports performance clinic that offers off-season training and injury risk reduction for professional athletes, in-person and remote sports performance programming and coaching, on-field rehabilitation to prepare for return to sport, post-surgical rehabilitation, and rehabilitation of sport-related injuries. Nicole was also a collegiate soccer player at St. John's University and received her Doctor of Physical Therapy from Emory University School of Medicine in 2015. I recently encountered an article that Nicole wrote where she makes a case for open chain exercises in ACL rehabilitation. And the open chain, closed chain debate in ACL rehab is one of those unnecessarily controversial topics where, for whatever reason, people think that you have to choose one or the other. But I think Nicole does a great job of summarizing the research for open chain movements and the stress they place on the ACL and the knee relative to movements and exercises, mainly closed chain ones, and functional activities like ambulation that are considered acceptable during the early stage of ACL rehab. And it turns out that the open chain movements, as far as the stress they place on the ACL, if they're loaded properly and through certain ranges of motion as you progress through the rehab process, they really aren't dangerous. So she kind of dispels that myth, but also speaks to some of the unique benefits that open chain movements have in ACL rehab, because an open chain movement like a leg extension does isolate the quad. And if all one does is employ closed chain exercises, there is a chance that the athlete can compensate and kind of work around the knee and utilize maybe like more of a hip strategy and not load that quad. And if you don't load your quad early on, it could be something where the athlete doesn't reach his or her full potential later on in rehab. So there's a link to that article in the show notes. I think it's a definitive resource on the subject, and it's really concise, but also very thorough as far as the research that it includes. And it just, in 5 or 10 minutes, I think it's, hopefully it closes the case on whether we should be employing open chain exercises in ACL rehab, because I think there are some unique benefits that Nicole does a great job of outlining. And originally my intent was just to talk about that ACL open chain article that Nicole wrote, but as I looked into her work a little bit further before I invited her onto the show, I encountered a course that she created about the ethics of return to sport decision making. And it's a really fascinating resource. There's also a link to that product in the show notes. But she really does a great job of introducing all the key stakeholders in the return to sport process, and provides several case studies that are really interesting, where you wouldn't a lot of times think of them as ethical scenarios. But from a return to sport standpoint and a rehab standpoint, pretty much everything we do has an ethical component. And she doesn't tell you in this resource how to think or what you should do, because she acknowledges the complexity and all the contextual variables that can influence return to sport decision making. But I think she does a great job of telling us what questions we need to be asking when it comes to the clinical aspect, the emotional intelligence aspect, and the ethical aspect of return to sport. All right, Nicole, thank you so much for joining us. Would you please begin by talking a little bit about your clinical practice in physical therapy? I know it's unique in that you actually don't always work in a clinic or an office, but sometimes your office, so to speak, is on a soccer field, which I think is pretty cool. So would you mind getting into a little bit, again, on that clinical background and even your athletic background a little bit? Because I think there's a congruence between those two things.
Yeah, of course. Thanks for having me on. So basically, I've always kind of been interested in the return to sport concept and the idea of taking someone from their injury and not just to being pain-free. That's not always been my goal as a clinician, is to get someone pain-free, but to functioning and performing. So I worked in a couple different, outpatient sports medicine orthopedic clinics since I've graduated. And I just didn't, no matter how good the setting might have been, like my first job was in a sports performance center and I loved it there. But it still isn't, you still have limitations put on you by insurance companies mostly. So it's hard to really do everything that you know that athlete needs to return to how they should be performing in those types of systems. So I have my own cash-based practice. I do nothing with insurance companies. I don't even supply a super bill because I purposely don't want to deal with any of it.
Oh, okay.
Yeah, because I don't want, what I can foresee happening is if I start giving super bills, then someone someday is going to say, oh, my insurance company, isn't going to pay me back anymore, so I'm going to go somewhere else. It's like, if we just don't even set the expectation at all, then that I've found that that's been better for me. Probably a little bit of the lazy way out because I hate insurance companies. So
I hear that 100%.
I just don't want any involvement. And I just find that I have so much freedom in how I treat now. So like you said, some days that means I'm in a gym with an athlete. Some days that means I'm at someone's house helping them after surgery figure out how to go up and down their steps, in and out of the bathroom. And sometimes I'm on a soccer field, which is great. And I love that. It doesn't really feel like work or like an office when I'm there. So that's been the most fun for me. And yeah, I mean, I was a college soccer player. I played at St. John's in Queens, New York. And then I was a soccer coach. I wanted to be a college soccer coach or professional soccer coach. And my college coach told me that I was too smart for that and that I should go do something else. So he's the one who actually kind of helped me see where I can bridge soccer and physical therapy and sports medicine. So that's what I try to do. I have a strong background in soccer, so that's just kind of what I lean towards. But really, any athlete I love working with.
Yeah, and that's kind of how I encountered your work, was just on social media, seeing some of the return to sport pieces that you wrote. And the first one that really caught my attention was the article about ACL rehab and open chain exercises. And that led me to your website, where I actually watched your ethics, the ethics of return to sport. So I want to kind of get deep into both of those things, because they're both awesome resources. But I guess I want to begin by talking about the open chain exercise and ACL rehab, because to me, it's one of those things where there's so many faux controversies in rehab and performance. It's like people have these endless, in my opinion, just completely wasteful debates about whether we should do like single leg exercises or double leg, as if like you have to choose between one or the other. And like closed chain agility drills versus like open chain chaotic. It's like, most good coaches, or what I would consider competent coaches, are always doing like both of those things. And there's an appropriate progression and an appropriate time for all these different things. And when it comes to the open chain thing in ACL rehab, one of the kind of myths that you expose in your article is that it's dangerous to do open chain exercises. But you actually have some really good data and some studies that you cite where, like, relative to other things, activities that have been quantified in terms of ACL stress that are deemed permissible in the early stages of ACL rehab, you found that those things are actually more quote unquote dangerous than an open chain exercise. So can you get into why we should get over this thing about open chain exercises being dangerous, so to speak, when it comes to even early ACL rehab?
Yeah. So to your point, like, my argument is never like, oh, do open chain but not closed chain. It's right. We should do both. And I think the argument of, we can only do closed chain or that open chain is dangerous, that I was like, hang on, how do we know that? What makes it dangerous? And so what the myth was, or what the belief has been, and what I was taught in school, what I'm sure many people were, is that open chain exercises strain the ACL. So my first thought on that was, well, why is that a bad thing? Isn't that what we do? Right after a hip replacement, we get the person up and walking because we want to load to help with healing. So that was my first thought. And then I was like, well, what are the things that we typically do early in ACL rehab, and what types of strains do they put on the ACL? And so there's some really good data out there, some really good articles that show that things like body weight squats, walking, those are two of the things that we do first session with somebody. Is we do gait training and we have them do body weight squats. So the amount of strain on the ACL during those two tasks is really similar to an open chain knee extension exercise. So yeah, it's just if that's the argument that it's dangerous because it's too much strain, well, that doesn't hold water, because you have no problem doing body weight squats and having them walk. So there should be no problem having them do open chain exercises. Now, I will say, of course, that doesn't mean that in the first week post-op, I have them sit on a leg extension machine and go full range at max effort, because that would be silly, because nobody does any exercise max effort right after surgery. Or, the first time when they're deconditioned or they're a novice athlete or anything else. You always start at what their capacity is and then build it up. So same thing with open chain exercises. You just find an entry point, find what their capacity is, and then build it up.
Yeah, and that's one of those things where when people say, oh, like it strains the ACL, like anytime a muscle contracts around the joint, it's going to put stress on that joint. And that's kind of the point of rehab, where I think the fundamental issue is like, are we putting so much strain that it's going to cause like a graft failure or some kind of a catastrophic failure? And you make the point that like, even with something as simple as ambulation, the forces on the ACL are higher than what they would be with a very submaximal like leg extension, in a range of motion that's deemed safer. And I mean, even, like I don't personally do, full range of motion leg extensions early rehab either, but because it's like, if something goes wrong, then you're obviously going to be deemed irresponsible. But at the same time, like after a surgery, there's so much inhibition anyway that like, is the nervous system going to allow such a high output that you're going to destroy your joint? Probably not. But again, I think there's reasonable boundaries we can draw, and we can get into the specifics of that later. But I think that the next point I want to kind of get into with you, because you make this really well in the article, is people talk about like, closed chain versus open chain as if like, if you say that you do open chain exercises, it means you don't do closed chain. And I think that most people have this idea that closed chain exercises are kind of more functional, whatever that means. And I think that functional has become kind of a bastardized, ambiguous word, because function is always contextual. But you make a case that like there are actually very unique benefits to open chain exercises that you don't get with closed chain, and that's why we should do them. So can you get into like, what are the unique benefits of open chain exercises that actually in the long run are ultimately going to improve function and presumably make them functional in the long run?
Yeah, so absolutely. Like I'll still do closed chain exercises like squats, deadlifts, lunges, all of those things. Great to do. That should be included in the rehab. But I would say that we need to include open chain because right now, now this may change with more research in the next couple of years, but right now as we stand, the body of literature supports that the biggest predictive factor of going on to have a second ACL injury is quad strength. And so to me, that makes that the priority in rehab, is getting the quads really, really strong, both of them, because the contralateral side is just as much at risk as the ipsilateral side, sometimes more so. So having said that, yes, we can strengthen the quads with closed chain exercises. Sure. Goblet squats, trap bar deadlifts, Spanish squats, all of those things, great for loading the quads. However, there's also some great research showing that after an ACL reconstruction, what patients tend to do is subconsciously shift the load out of that surgical knee. And we see this early on when we see the interlimb compensation. So if it's a right-sided injury, they'll shift their weight onto the left side. We all see that. It's something we all, when we're working with this population, try to cue and correct, and eventually it sorts itself out, we think. But what actually happens is that instead of an interlimb compensation, Susan Sigwart at USC and her research team, they found that around 3 to 5 months after surgery, there's a switch to an intra-limb compensation. And so now they're unloading that surgical knee, and instead they're shifting that load into the hip and or ankle. So we can't always see this, especially with something like a bodyweight squat or, you know, a bilateral closed chain task. We can't see that happening. We can only see it if we have, you know, kinematic data at our disposal, which most of us probably don't. So since that shift occurs and they're not loading their knee appropriately, that means they're not, exercises that we think are loading the quads aren't actually loading the quads as much as we would hope. So that's where something like a leg extension comes into play, a knee extension machine, because there's no way to cheat that. You have to utilize your quads to perform that movement. That's the only thing that's going to do it. So it's just a way to ensure that you're doing everything you can to get this person back with a reduced risk of re-injury, because that's really the name of the game with ACL rehab, is don't let it happen again, because they're at such high risk of a re-injury. So any way that we can do that, which right now it looks the best thing we can do is quad strength, then we have to include it.
Yeah, and I think that's like where people get all caught up in this functional training, is the idea with functional training is that, like, you know, the body doesn't isolate muscles and it works as a unit, which is true, but the confounding factor here is in a surgery, when you have inhibition at a specific joint, if you don't address that inhibition and isolate that individual joint early on, now you've actually never sufficiently stressed that joint, so that when the person goes back and plays on the field and they encounter stress that you can't account for in a training environment, now that joint is not ready. And so have you seen, like, even in things like with a hop test, like if you don't isolate the quad early on, a gifted athlete can learn to compensate and develop, you know, symmetrical readings on a hop test, but maybe use more of like an ankle or a hip strategy to do it. So I don't know, like, how do we get around that type of compensation unless we isolate the quad early on? And to your point, I don't know how we do it unless we're doing a leg extension machine, right? Like what else do we do? Otherwise we're guessing. Yeah,
exactly. Yeah. And that's exactly the point. Otherwise we're guessing. Like if you aren't sure and you don't have like a valid way of measuring and assessing that, then you're guessing.
Right.
And I'd just rather not do that. I'd rather not just be guessing through someone's ACL rehab. But yeah, functional has come to mean so many different things. To me, it's going to be different person to person, right? Like functional is what does that person need to be able to do? And for athletes, they need to be able to, especially soccer players that I work with, decelerate, accelerate, change direction, sprint, jump, land. And they need strong quads for all of those things. It's not really beneficial for performance, let alone injury risk. For what ends up happening is when they go back to sport and they are now on a quad that is weakened, and so they take the load out of that knee, like we talked about. And so now they're going to go try to land and or change direction and decelerate on a limb that's doing more of a hip strategy. So more of an extended knee, trunk flexion, and then rotating and pivoting off of that. And that's an ACL injury waiting to happen. You know, the ACL tear is when your knee is at or near full extension.
Yep.
So if they're not loading that knee and getting good, strong quadriceps control eccentrically during those tasks, during deceleration and landing specifically, then they're going to utilize a hip strategy. And then that's when we see valgus forces at the knee, is when they're in that more extended position, hip strategy, the quad's not doing it, so then it has to go to the glute, and then it's too much for the glute to do, and then we see knee valgus. So I think a lot of people take this idea of functional, meaning it has to, for whatever reason, include an unstable surface and 7 different colored bands, and that doesn't happen on a field. That never happens on any field or court. So I think if we work under the definition of functional as being something that applies to what that person has to do, then we're a lot better off.
Yeah, and I think that sometimes you have to constrain. It's like the whole training. You have to constrain a drill or an exercise to stress whatever tissue it is that you want to stress. So like, yeah, even when it comes to like change of direction, there's this whole like, people are obsessed with the concept of self-organization, but self-organization is contingent upon having options from which to self-organize. And sometimes you have to isolate individual components of that system to make sure that you can call upon them to self-organize. And to your point, if you don't have quad strength, now when you go to change direction, you're not going to be able to produce the right shin angles. You're not going to be able to load your knee effectively. You're going to have to rely on a hip strategy. So the only way to do that sometimes is to kind of, it's also like specificity. We're so obsessed with specificity. How do we mimic what goes on, in the game? But sometimes you need to like isolate things and constrain things before you can get really specific. So in my opinion, sometimes the best way to be functional is to be as far away from specific as possible and get on a leg extension machine and strengthen your quad. But like when you say that, it becomes just so polarizing. So I would encourage anybody to read your article on that, because it's not like you're saying do open chain and nothing else. You're saying like there are unique benefits to open chain. Here's why you should do them as part of a comprehensive rehab strategy. So that's a little bit abstract. When it comes to like specific stuff, what's kind of your time? I know everyone's like somewhat unique, but your basic timeline and progression for like, what's the point at which you generally feel comfortable in ACL rehab, getting somebody to do like a leg extension machine through a full range of motion? How do you respect the arc of death and terminal knee extension early on? Like, how are you getting from kind of day one post-op to the point at which you feel comfortable loading that quad through a full range of motion with a lot of external load?
Yeah, so there's no strain on the ACL from like 90 to 60 degrees of knee flexion. So immediately I'm comfortable with that range. Now, what usually happens is that I'll have the person I'm working with right after surgery just do an isometric at, if they can't get to 90 degrees of knee flexion, which often they can't that early, at 60, 70 or so, somewhere in that 90 to 60 range, I have them do isometrics, just pushing into my hand, just whatever amount of effort they feel comfortable putting in. I do tell them not a maximal effort. So I tell them to whatever their maximal is, back off a little bit, because there will occasionally be that one person who's like, all right, let's go for it. Like, let's start this physical therapy program, and push really hard. And it's like, okay, we don't necessarily need that day one. But so I always start in that 90 to 60 range day one. And I always start with isometrics, because I find that to be a better way to start getting a good quad contraction than just quad sets. So I still will do quad sets, but I think it's a good idea to also get them in a different position. Then I'll do those manually resisted isometrics at different range, at a different angle, so at varying angles through that 90 to 60 range. And then if they're comfortable, I just have them open and close 90 to 60. And I'll keep my hand there so that they can't go past it. So immediately I'm comfortable with that 90 to 60 degree range because there's no strain on the ACL. So as long as they're comfortable doing it, I'm comfortable having them do it. After that, then usually for the first 4 to 6 weeks, I'll usually stay in 45 to 90 degrees. And again, usually starting with varying manually resisted isometrics at varying angles throughout that range. And then as they're comfortable producing an isometric contraction at those various angles, then I'll have them go through an isotonic contraction through that range.
Like on the machine with some external load?
This is first, no, just their leg.
Okay.
And then, because I just want them to be able to produce a quad contraction in that range. Now, if they're comfortable with that, and that's fine, then I'll get them on the machine, start off with an isometric. So this is all in the first 4 to 6 weeks.
Yeah.
I'll get them on the machine. They push into it as hard as they can. I'll start off with 30-second isometric contraction. I'll tell them to do between 50 and 70% of max effort. And and then rest for, 2 minutes or so, because I want to work on getting a good strong contraction. I don't really want to do that under fatigue just yet. So that's kind of the parameters I work with initially. At around 6 weeks, again, sometimes it's sooner, sometimes it's later, but around 6 weeks is when I have no problem opening up that full range. Often it's sooner, but there are times that either the athlete's not comfortable with it, or I'm not comfortable with their amount of a quad contraction just yet, or their quad strength just yet, or they're having some discomfort, or any other potential issue in the 90 to 45 degree range that I delay opening it up. One of those reasons that I delay opening it up is if they've had an allograft or a hamstring autograft. So those take a little bit longer to heal. So for those, I'm definitely waiting for at least 6 weeks to open it up full chain, full range, full 90-0, because there's soft tissue attachments. So instead, the bone patella bone, that has the bony plugs, so that's going to heal a little bit faster. Whereas the soft tissue attachment of a semitendinosus or an allograft, I'm not as comfortable progressing fast with. So you have to always respect biology. But that's kind of my general timeline of how I do it. Again, like you said, like everyone's going to be a little bit different. I have someone right now who was able to do it super early, and I had to kind of hold it back just because it was a hamstring autograft. So.
Yeah, I like asking that to different therapists because it's just one of those, like, there's some clinical judgment involved in it. And the consensus seems to be that, I mean, there are people who aren't touching open chain stuff for like 6 months, so like the quote unquote, even the quote unquote riskier PTs, which would be someone like you based on like I think the probably how we look at things, but I think risky more in a good way. And we'll talk about that with the ethics in a minute. I think people are saying like, all right, like no one's really doing full range, external load until like almost 2 months out, open chain. So it's not like you're saying like, hey, let's day one, let's go get a leg extension and crank out full range of motion. Like you've got a progression. You're avoiding any kind of ACL stress in open chain for almost the first month to 6 weeks. And then only at like maybe 6 to 8 weeks are you even considering going through that full range there. So to me, seems more responsible and prudent than risky. But I think because we've been so conditioned to think that open chain exercises are bad and dangerous, we're like, oh my God, we can't do them for 6 months. But the crazy thing about that is people are running at 3 or 4 months, but they're not doing a leg extension until 6.
Yeah,
so
exactly.
What do you think is really going to be more dangerous? It's like, I think we were a little bit distorted with some of that stuff, but I'm going to post a link to that article you wrote in the notes. And I hope this is going to be kind of like a case closed type thing, because you really do a great job of hopefully putting it to bed. But I have a feeling that the fake controversy is going to persist because what would we do if we weren't fighting over crazy things,
Exactly. Because there's always going to be those people who are like, well, I haven't touched open chain in the 25 years I've been practicing and I'm doing well. So.
And again, what's well? Like, how do we define that? And
yeah.
It's not a controlled study relative to what you could have been doing. How do you know? It's like.
Exactly.
It's a certain point where, I guess you could just say your piece and then move on.
Exactly.
So,
and that's all you can really do, especially in social media, is just like put out what you want to say, your objective statement, and then back away.
And that's why I appreciate your article, because like you can go back and forth in these threads and they become after a while, almost like more about fighting than about like getting to anything definitive. You wrote an article. It's like people want to, abide by it. Cool. If not, but like, you don't need to get involved in this mudslinging anymore.
Exactly.
You put the effort into like actually writing a well thought out article, which kind of segues into the next really, I thought, well thought out resource that you created, which was the ethics course. And as you know, like in our field, especially in like, sports medicine, orthopedics, everything tends to be like very like exercise centric, manual therapy centric, programming centric. And yet you created an ethics of return to sport course, which was really different than a lot of other resources that I've encountered for people that like focus on the sports and performance side of things. But I mean, it's 2 hours, but that could really be an entire semester long course in PT school. Like, there's so many layers to it. What inspired you to create that resource?
I guess a couple things. So the thing that really kind of made me do it was Matt Bodman from South Coast Seminars. He was putting together he was hosting Tim Gabbett for a training load workshop course. And my husband and I were both attending it. And Matt Bodman reached out to me and was like, hey, I want to like put together an ethics course for PTs and athletic trainers. Would you be interested in doing it? Like, on return to sport. And I was like, sure. Yeah, that sounds good.
Okay.
So that was kind of like the catalyst for me doing it. But it's something I've always been interested in. And I can pinpoint like a few defining moments that have made me really interested in this side of things. The first is I went to Emory University for physical therapy school. My husband did as well. That's where we met. And we had an ethics course there, and we had this professor, Dr. Bruce Greenfield, who's amazing. He's a sports and orthopedic physical therapist, but now he just does ethics. So he's on like the ethics review board at Emory. And I had our semester-long project was to write a term paper, so to speak, and mine was on return to sport decision-making. And then I just like the way he made us think about things, where I think a lot of times ethics, and in California, for example, we have to take an ethics course every cycle, I think. And a lot of the ethics courses are just so dull and don't always apply. Like the first principle of like do no harm, that does not apply in sports. We are knowingly doing harm sometimes, or knowingly risking harm, not doing harm, but putting athletes at risk of harm. So like the very first thing that we're taught, this do no harm principle, just gets torn to shreds in sports. So that just made me think a lot. And then I have one of my college teammates, Vela. She plays professionally in Sweden right now. And one of the first, I think it was her first year playing professionally, she was having some back pain and reached out to me. I was still a student in PT school, and she said, her MRI showed a herniated disc, and whether or not that means anything clinically in her case, I don't know. But she said she had a game coming up where she was supposed to be playing against Marta, who's one of the world's best women's soccer players, one of the world's best soccer players who happens to be female. And so it was a big deal. It was a big game. And Vela was trying to be seen by other professional scouts and national team scouts. So this was a big deal for her to play in this game and mark one of the world's best players. So in my mind, I was like, surely there are things in life and in sports that change the amount of risk you're willing to take. Like I can say all day long, hey, you have a herniated disc, you shouldn't play soccer because it's a contact sport and who knows what might happen. But then there's things that change that. There's things that say, hey, I'm willing to take more risk on this. So I thought that was a really cool concept to explore and try to utilize the ethical principles we do have within the APTA Code of Ethics and our state practice acts, and see maybe where they fall short or contradict each other sometimes.
Yeah, and what's really cool is like, I think you do a good job of asking questions, but you also respect the complexity of some of these scenarios. And you're not saying like, here's the best way to handle it, because there are some situations that are from an ethical standpoint, like very clear and definitive as to what you should do and what you shouldn't. But part of what makes this so difficult is that you talk about like some of the stakeholders in the return to sport process. And when you have more stakeholders, you realize you've got kind of different interests. Sometimes they're aligned, sometimes they're conflicting. But if you look at all of the stakeholders like individually, you realize that they all kind of have legitimate things they're looking to achieve, but sometimes those things aren't always in the best interest of the medical outcomes. So can you talk a little bit about, like, before we even get into the other stuff, like who are the stakeholders in this return to sport process?
Yeah, and that's always going to depend on what level of competition you're in. So at a youth level, if we're working in an outpatient clinic, for example, we have the athlete, their parent, their coach, maybe usually their gym teacher is somebody that we need to include as well. their friends, their teammates. So those are all people that we need, the referring physician, of course, these are all the people that we need to consider in this process. At the professional level, we would have sports scientists, sports medicine staff, sports performance staff, director of high performance, coaching staff, the GM, the player's agent, the player's family is still important here, the teammates, the fans, the media. So it gets a little bit more complex. And what I think is really important is when it comes down to it, we're dealing with a human being, and human beings are inherently complex systems. Working with an athlete is not just an athlete, they're also a mother, a sister, a teammate, a friend. So there's a lot of layers, a lot of contextual layers to each person that we need to consider. So identifying the key stakeholders is important because it's important to recognize that our voice is not the only one being heard, nor should it be. There's a couple different people who have a say in what happens, and have a say in how things should progress. And as long as all the stakeholders still keep the athlete in the middle of this process, and are still all coming from a place where the athlete's best interests are being kept at heart, then we can all move forward together. I think it's important for every stakeholder to recognize that we should all ultimately have the same goal, and that's to have the best outcome possible for the individual athlete we're working with. We may all disagree on how to do that, but as long as we can agree on that being our end goal, then it's possible to move forward together. And we need to hear everyone's perspective because that's what the athlete is hearing.
Yeah, when you talk about these stakeholders, it's almost like you're teaching an emotional intelligence course because you have to be so aware, hyper aware of how every party involved in the process is like the lens through which they're going to look at the problem. And it's difficult because it's not clear like who decides whether the athlete plays or doesn't, right? It's not like there's this hierarchy where, the GM can say like he or she is playing or they're not. Ultimately, kind of the athlete probably is going to make that decision, but the athlete also has a lot of people in his or her ear, which makes it difficult. So like from a medical standpoint, because, as medical people, we like to think that like we should probably be the gatekeepers to return to sport during a medical situation. But it's also like the athlete, to your point, might decide that they're willing to tolerate more risk. And you bring up kind of that, like the athlete in the game 7 of the championship scenario, where it's like the athlete might have a soft tissue injury that predisposes them to something more catastrophic. But if that athlete, if they play in game 7, they get to bond with their teammates, maybe they're going to get like a $2 million bonus for winning a championship. Maybe, like it can solidify a legacy in terms of being like a historically great player. Like if I was in that situation and I'm not talented enough to ever be, I might risk like tearing my ACL for all those things. So what is the job of the medical provider in that scenario, beyond just really providing the athlete and all the other stakeholders with information? What really more are we doing than saying, here's what I think, like here are the risks based on my analysis, but we're not really deciding, are we?
I would say that that's our role is to educate and provide our objective perspective and say, and not just in the moment, because almost everyone else around the athlete is thinking in the moment. So I do think our unique role is to think long-term as well. Like, how is this going to look for you when you're 70? Because that's really tough for athletes to do, is to think about what their life will be like after they're not athletes anymore. So I think that that's a unique perspective that the medical staff, rehab staff, that we need to bring to the table. So I think that's our role, to say, these are the risks. I'm worried about this. I'm worried that because of this soft tissue injury, that when you give it to them in terms they understand, when you land, that you're not going to contract your quad hard enough and you might tear your ACL. Or I'm worried that your calf has been bothering you on and off for the past month. It's been getting a little bit worse recently. Your load has increased recently because we're in a championship series. I'm worried that you're going to jump and tear your Achilles tendon. So if we give it to them in terms they understand and say, this is what I'm concerned about, then at least we, and you know, do the simple teaching things, have them tell it back to you, ask them if they understand, say, what are the risks that you're willing to take? Are you willing to risk, you know, possibly missing next season, having to undergo surgery that may or may not be successful, having a long, tedious rehab process? Are you willing to take on the risk of that for this game? And maybe they're early in their career and they're not willing to do that. Maybe they're planning on retiring soon anyway, so they are willing. Or maybe this will, like you said, seal their legacy. You know, if they're going for a three-peat, they're going to be written into the Hall of Fame. Or if a contract year is coming up and it's up for a couple million more dollars. Like, who am I to tell the athlete, like, the $5 million isn't worth this injury? Maybe it is. I don't know that. You know, I can't say that for that athlete. So yeah, I think our role is to provide a clear, objective data. But I think maybe sometimes what we miss is making sure they understand what that means to them.
Yeah. And the hard part is everything that we're telling the athlete is still a hunch. Like, we can't say with any kind of validity or reliability, like, well, you've got this % chance of an injury if you play. Because there have been people who have played hurt and nothing has happened. And there have been people who, like, by every kind of metric, whether it's readiness metric, like HRV, load management, like, they look good and they get hurt. So, and I think you also talk about, like, there's differences among various injuries, right? Because, like, somebody might say, okay, I am okay with tearing my ACL if that's, like, the worst possible scenario. But in a contact sport, for someone who's had 10 concussions, where one more concussion could permanently disable them, that's also a different kind of calculation. And you get into all those things in the course. When it comes to, and we talked about this earlier, the idea of, like, do no harm. And I thought it was really cool when you talk about, like, as rehab providers, we really can't abide totally by that ethos, because in order to prepare somebody for sport, there's some element of risk. Like, the game is risky. The only way to prepare for the game is to systematically induce risk. So from, like, an ethical standpoint, and because I think sometimes this gets lost, like, would you say that complete risk aversion is unethical from the standpoint that you're kind of trading the potential for harm in the present for the potential for harm in the future? Whereas if you, like, introduce some risk early on, you know, maybe, like, in that, and part of it is also, like, the whole finger pointing, right? Like, if you're not aggressive in your rehab, no one's going to get hurt on your watch. But then you could say, like, okay, well, it's the strength coach's fault or the head coach's fault, but maybe it actually was your fault because you didn't hand them off when they were actually ready for that stuff. So how do we reconcile the do no harm principle with ethically preparing that athlete for the rigors of the game?
Yeah, I liken it to like, you ever seen, like, free solo, or, like, people who do, like, the crazy rock climbing, like, they take calculated risks. And they'll say, like, in Meru, is that the one documentary, the one movie on one of those?
Meru's a climbing documentary as well.
So in Meru, they're, like, in a tent and they're talking about, like, I know that there's risk involved in this. Obviously, I'm hanging off the side of a mountain in a flimsy tent. But I also know what risks I'm not willing to take. I know what risks I'm ready for, and I know which ones I'm not. So they're all calculated risks. And I think that applies to sports rehab as well, in that if we are just completely risk averse and we just have them do, you know, simple exercises that aren't going to apply any type of stimulus that we need to cause adaptation that we're looking for, but we're being safe, that's actually doing more harm than good, because we're not actually preparing them for the things that they're going to go out there and do. On the other hand, if we do things that are too risky, so we have them do something that they're just clearly not ready for, we're having them do single leg hopping and landing the first week post-op, that's probably a little too risky. So to me, it's all about taking calculated and measured risks, figuring out what is an okay risk for the athlete like what they feel like is an okay risk? Do they feel comfortable with it? And then what in our objective data, what in our experience, what in the research tells us is an okay risk to take.
Yeah. And you go over a lot of case studies in your course, and we don't have time to touch on all of them, and we could do a whole episode on each of these scenarios, but I want to give people kind of an idea, because you do a great job of kind of assessing what questions do we need to ask in each of these scenarios. And you don't say, here's the answer, because there's so many contextual variables that answer depends on. And you give very simple scenarios, because you'd have to ask, well, what about this? What about this? To really get to like, what's the right answer? But I want to kind of go over some of them just so people can hear your thought process. And again, I encourage them to watch the course, because you go into a lot more depth. And this is really timely as a scenario. How do we, from an ethical standpoint, or what questions do we ask to determine whether physical therapy, outpatient sports physical therapy, should be considered essential in light of what's going on with COVID? I think it's a good place to start, and you get into that in the course.
Yeah. So when I recorded I created the course over a year ago, but I kind of revamped it and recorded it in March. So just when everything was kind of like shelter at home. So it was I thought we would be done with it by now, but hey. So that was in the time where there was kind of a lot going around on social media of like, why are you still seeing patients in your clinic? You shouldn't be doing that. Or, people saying like, how can you close your business down? You need to make money. And so being a business owner and a clinician, I was like, I see both sides. I see, I see the need. Hey, I need to pay my bills. I need to buy groceries and eat and contribute to my family. So I need to make money to live. And that's okay. That's fine. That's essential. I also, I said the gym that I was utilizing closed, which it should, because I didn't really feel comfortable going into a gym anyway. I thought that was risk I wasn't willing to take for my health and my client's health. So luckily with my business model, I'm able to be flexible and adaptable and see people in their homes, take extra precautions. But I think that there's there's very rarely one answer for every single person. Like there's never one thing that applies to everyone in a given scenario. And I think that just kind of the threads I was seeing on social media, like, how can you be open in a time like this? Or like,
and I saw that too. And the majority of the people that said that were in academic positions where they were getting paid to teach virtual classes. So it's easy to be righteous when you're getting a paycheck,
Yeah.
I'm not saying that was the only people that were saying that, but it seems to be like a big proportion of it. Yeah.
Yeah. And I also see the side of like, hey, does every visit count as essential? Like, is that ankle sprain patient really an essential thing for you to be seeing? Is it so essential that you're willing to risk your health or the health of the people who come into your clinic? So I think that there is probably always a middle ground, somewhere in the middle that works for most people. So again, like in the course, I said at the beginning of the course, and you've mentioned it a couple of times, is that I try not to give any answers. I purposely tried not to give any answers in the course. I just wanted to keep asking more questions.
Yeah.
And the way I do that is I kind of, this might make me sound crazy, but I always think of things with like parallel universes. So like if like choose your own adventure books, like the Goosebumps series when I was a kid was like, pick your ending. If you can do 10 push-ups, it's go to page 37. I kind of always think of my decisions like that. Like, okay, I can choose this. This will most likely lead me here, which will most likely cause this. If I choose this is the most likely outcome. And I kind of try to look at all of those alternate endings and decide on which one would be the best ending for me, and that decision, and then choose that path. That doesn't mean that the other ones were wrong. They just weren't the one that led to the outcome that I thought was best suited for that scenario. So that's kind of a little peek into how my brain works with these complex topics. But yeah, I think that there's never one solution. And with should clinics be open? I do think that probably there are times where it is essential for us to see people. My dad had a knee replacement surgery in December, right before all this. I think there are times that he needed to be seeing someone. I think that there were also a lot of clinics still seeing 15-year-olds with ankle sprains that didn't necessarily need to be seen.
Right. Yeah. And it's tricky because there's kind of a bottom up and a top down way of looking at it. Like, even if the government said, look, like, we'll let you guys decide what's going to be essential. Like, for example, in New York City right now, they allow outdoor seating. If tomorrow they waved a magic wand and said you can eat indoors, I don't even think I would, even if I was legally allowed to. And I think a lot of times the patients kind of self-regulate. So there's an element like, it's who determines what's essential, right? Is it a top down or a bottom up? And then beyond that, there's so many individual behaviors that you have to account for, because if you see one patient for something that you might deem essential, well, if that patient is riding the subway and going to parties, that's different than if the patient is wearing a mask and living like a monk the rest of the time. So again, you do a really good job of kind of talking about like all the variables that can influence it, which is why you don't provide an answer. Another scenario that I thought was interesting was you talk about like you have an athlete who, based on like kind of your objective and subjective analysis, you think that athlete's ready to return to play. The athlete doesn't feel ready psychologically. And then there's pressure from the coach and the GM, like, hey, why isn't this person ready to play? And there's also, you have a selfish interest, because the longer that person takes to get in the field, it kind of reflects poorly on you, like you're not doing your job. So how do you handle that, right? Because you feel like you've done your job, but the athlete doesn't feel psychologically ready, and you have all this external pressure. Kind of what questions do you ask to navigate that?
Yeah, and that's something that's important because, well, first of all, I will say a little caveat to that is that usually, most of the time, of course, there's always outliers. Most of the time, though, if an athlete is physically ready, then psychologically they feel ready too. They usually go hand in hand.
Yes.
But there is the very famous example of Derrick Rose, who, by all accounts, was physically prepared. Enough time had passed, but he didn't feel prepared to step onto the court. And that's really important. And that's what, as a clinician, we have to be curious, and we have to be comfortable with that discomfort and the unknown, and be able to say, okay, I know that he's ready physically. I don't think him stepping on the court tomorrow, I don't think he's at an increased risk. So what is it that is making him feel like he's not? And then, like I said, just be curious and explore that. Why is it that he doesn't feel psychologically ready? Are you missing something physically?
Yeah, that's part of our responsibility, actually.
Yeah, it really is.
Yeah.
If they don't feel ready, is it something that I'm missing from a physical perspective? Did I test this in a valid and reliable way? Did I, was I on track with his progress throughout the rehab program? Or is this something that doesn't have anything to do with the physical side, and I should have him, maybe refer him to a sports psychologist at this point? But I think what always rings true is that without communication, this just ends up being a lingering problem.
Yeah.
And I think that's kind of like any of the examples I give in the course, is communication is always going to be key. If I'm always communicating in an effective way with the athlete, develop a relationship with them, and the coaching staff, the performance staff, the other medical rehab staff, if we're all staying open and communicating effectively, then there shouldn't be surprises like that. I should be able to say to the head coach or to the performance coach, or any of the assistant coaches, hey, this is where we're at with the rehab. He's doing great. I'm a little concerned though about this. And I think that if we take, and I know this is hard to do because the team is who's paying you, and it's hard to get into pro sport, and it's a job that doesn't have good job security. People get fired all the time in high performance. So I recognize that this is difficult to do, but I think that this is what makes people truly great at their jobs, is being a good people person and being able to effectively communicate and say, I'm a little concerned about this. I don't know why he doesn't feel ready, but it's important that we validate how he feels about it and explore why. I'll explore why, from a physical perspective, is there a chance that we can refer to a sports psychologist to get their perspective? And I don't think that reflects poorly on a clinician that, I don't have an answer right now, but this is important and we need to explore it. And I'm going to do my best on my end. Here's how the team can help on this end. I think that reflects well on you, that you're willing to explore the unknown and willing to work with others on a challenging situation.
Yeah, it's so interesting when you brought up the sports psychologist, because I've had patients where I felt like that was kind of the missing link. But even then, from like an ethical or an emotional intelligence standpoint, how do you raise that subject with an athlete? Because as soon as you do, there's a stigma associated with going to see a psychologist that like you have to tread just so delicately to bring that up. But I think that, what's cool about that scenario is, it's one thing to be able to have the quad strength, pass some hop tests, do high velocity running in your rehab. But there's nothing that we can do in our artificial environment to simulate the stress of playing in front of 20,000 people, that emotional stress. And then if it's like a really good, like elite athlete, where they like the entire franchise is depending on that person to come back and like save them, so to speak, you could see why people who maybe are physically ready wouldn't feel emotionally ready to do it. And you talk about how like we can't judge, we have to validate it. We have to look deeper because maybe it's something that we missed, and it's not just about the physical stuff. I think that the physical often kind of marries with the psychological, but it doesn't always. We've got to be prepared for those scenarios. Another scenario that I like that you brought up, because with a lot of this stuff, it comes down to, like, for example, in this scenario, I'm going to talk about confidentiality, which we value, and that's part of the code of ethics, versus privacy and safety. And how sometimes these things are not complementary, they can be at odds. And the scenario for this particular instance is you brought up a high school football player. He comes to outpatient physical therapy for a concussion evaluation. And because the athlete's a minor, the parents don't want you to disclose to the head coach or the athletic trainer that you may have found some concussion-related symptoms, because they want the athlete to play in the game regardless. So it comes down to like, well, the athlete is a minor. The athlete, in the eyes of the law, doesn't have agency to determine whether he or she shouldn't play or not. You want to value confidentiality because this is your patient, but at the same time, like, the athlete could be a danger if he goes in the field, right? So how do you navigate that scenario where you have parents, you've got confidentiality issues, privacy issues, and you've got a minor where maybe, like, the minor, if the parents weren't in the room, would be telling you, look, I don't want to play, but the athlete's afraid to say it in front of the parents. So
that happens a lot, actually.
Yeah. So, like, I know it's a lot of stuff, but, like, all right, what questions do we ask? How do we, like, attack this problem?
Yeah. So that one, I think the one underlying principle with that one is, if you think the athlete, like, is truly at risk of doing harm to themselves, you have to let the parents know that. There is a time and a place to employ scare tactics. And this is one of those times, saying, and I have no problem saying this in front of the athlete sometimes, if depending on how I think they'll take the information. But sometimes I'll say it to just the parent, sometimes parent and athlete, say, this can affect their long-term health. This can affect their daily functioning. This can cause long-term brain damage. This can have early onset dementia and Alzheimer's. And do you want to, when you're 25, start having these crazy mood swings? And I'll bring up some of the famous examples from the NFL, former NFL players who have gone on and committed suicide. And do you want these things? Because this is what you're setting yourself up for by making decisions like this. And I think that there's a time and a place, like I said, for the use of scare tactics, and this is one of those times. If you still are getting nowhere with the athlete, now this scenario specifically was somebody working in an outpatient clinic who's not affiliated with the high school. So if I was affiliated with the high school, it's different, because then I can easily say to the head coach, because we're all working together for the case of this athlete. But if you're an outside member and you don't know the head coach, you don't know the athletic trainer of the school, and they've purposely gone to you to be outside of the school
Yes.
system. That's what makes it a little different. So if they explicitly say like, hey, we want to get him evaluated, but we don't want you to tell his coach because we want to keep this private, you have to respect that. But if there's anything that you think, he's inherently at risk for, or at a higher risk than you're willing to take, then do you call the head coach? Do you call the school? Do you just tell the parents, this is what he's at risk for, and then let them make their decision? I think that, again, in these parallel universes or these alternate endings, one path you can take is call the school. And then what are the risks, rewards of that? Next would be do nothing. What are the risks, rewards of that? Another path you could take is scare tactics with the parents. What are the risk, rewards of that? And another one is you think that the child doesn't want to play, the athlete doesn't want to play, and the parents are maybe forcing them. Is that something where child services needs to be involved? Maybe that's an extreme scenario that, maybe is an alternate path that you take as well. So all of these alternate journeys you can take, which potential ending are you most comfortable with? And that's kind of what you have to ask yourself.
Yeah, it's very subjective too. It's hard to say like this is the best one. And the last scenario, and this is kind of more systemic, you and I both don't have to deal with in-network insurance, which, will hopefully, it'll reduce our blood pressure and give us a couple more years on life. But one of the things that, a lot of people that do deal with insurance are bothered by is this idea that like, I just had somebody who tore an ACL and only got authorized like 10 visits or 15 visits. But at the same time, an insurance company, like their goal, it's a business, they're trying to make money. So I kind of see it from both standpoints, because if an insurance company said, okay, we're going to give you unlimited visits, we know most PT clinics would milk the crap out of that.
Yep.
And they see people every single day. And like, is the burden on the insurance company to allow somebody to be seen every single day for the entire year? But at the same time, the other extreme is like if they authorize 10 visits for an ACL, that seems kind of low. And, even in my career, I've never really, I've heard, fellow therapists and colleagues kind of complain about insurance companies, but no one talks about, okay, if you're going to complain, like, what would you reasonably think from an ethical standpoint an insurance company should be willing to authorize in terms of number of visits? So maybe we don't come up with an exact number, you and I, but like, how do we even go about, from an ethical standpoint, answering that question? Because if you take either extreme position, you could see PTs taking advantage of the insurance company. Right now, it's kind of the other way around, but what is an ethical kind of reasonable middle ground when it comes to that?
Well, there's two kind of topics that kind of spring off of this. First is to just directly answer your question. I would say for a youth athlete, they're not going back to sport before 9 to 12 months. So if we set, let's say 10 months, just to be somewhere in the middle. So 10 months, and then in order to be able to effectively train, like strength train, do the proper conditioning, everything that they need to appropriately get them to where they need to be at the end of those 10 months, I would say probably on average 3 times a week they would need to be training. Maybe in some cases 2 if they're doing something on their own, in some cases 4 if they're really far behind or whatever other reason.
Right.
So we'll say 3. So 3 times a week for 10 months. That's how many, like if we were just to give a straight up answer of like ethically how many visits should somebody be seen for that, that's what it would be.
That's, if my math is correct, 120 visits.
Yeah. Which like some, like when I used to work in insurance, not in insurance, when I used to work in practices that accepted insurance, like Blue Cross Blue Shield, for example, would do like the initial 60 and then they would allow another 60. So that actually worked out really well. Okay. So now, of course, there needs to be some kind of, and this is where I think insurance, like the whole system falls flat, is that there's always contextual factors. Somebody has a cyclops lesion and needs another surgery. Somebody gets an infection and somebody's not psychologically ready and then they need an extra month. whatever their timing of their season is, it'd be better if they had an extra 2 months. So of course, there's always going to be contextual things that an insurance company, the system that we have in America, is not set up to handle. But I think that this whole thing brings up a more profound issue that we have of, and actually the person who lays out this argument best is Eric Mira on his website, thesciencept.com. He has a blog about this, where we really have to decide, are we a medically necessary profession, or are we a service profession? And that's what makes the difference with insurance. Now, for me and for you, working outside of that model, if I do something if I'm sitting down and educating the person for an hour, that's valuable. That's worth the money of the session. Is an insurance company going to pay that? Probably not. So, I think that we just have this deeper, profound issue of, are we medically necessary? And if we're going to say that we are, then we have to prove that what we do is effective. Right. We have to prove that the modalities we use, that the interventions that we utilize, that they are effective in getting the outcome we want, and having a successful long-term outcome. I think that a lot of times in our profession, we do things and utilize things that make somebody feel good, but aren't necessarily medically necessary. And that's where we have a big problem, because if we're going to continue to do that, why should the insurance companies pay for that? Because then I can say, and I'm not going to knock any specific modality. That's not what I try to do. It's not what I'm here for. Yeah. But let's say I always hear the argument of, well, it doesn't do anything more than placebo. And I know that, maybe I know that it's placebo, but my patients really like it and they feel really good afterwards. Well, then where's the line? Because I can easily say, okay, every time I go get a facial and massage, I feel phenomenal. You're right. I have no pain. Yeah. Heck, when I go get a haircut, I feel great. That's the best that I feel all month, all 6 months. I haven't had a haircut in a long time.
You could open up a bar and charge health insurance for that.
Exactly. Yeah, exactly. So if that's the standard we're going on is, well, it makes my patients feel better. Yeah. That's not medically necessary all the time. So, and we can easily then push the line either way. So I get insurance companies not paying for things like that. I get insurance companies saying, I'm not going to cover this intervention modality, whatever, because it's not medically necessary. And we haven't proven that it is. So I think that's the deeper issue. But just to be precise on the actual question you asked, we could say.
No, that's super helpful, because it's really hard to be precise on it. I'm more interested in your thought process. One thing that working, in a cash base or at a network, model where there's higher deductible plans is, I know that I can't really rely on that person coming in 3 times a week. I'm not talking about a post-op, but for something that's a little bit more benign. And so because, ultimately healthcare costs somebody money. You might not see it if you're using your insurance, but it's costing somebody money, whether it's collectively or individually. It's coming from somewhere, because, if you get your health insurance from your employer, you're actually making less of a salary because of your health insurance. And you can make a case, if you put that money in the stock market, you'd be better off buying your own health insurance if there was more competition and price transparency. That's a whole other tangent, but having to kind of be really cognizant of all right, it's not cheap to go to an out-of-network PT for, even one session. How can I maximize the value of that session? And I'd even work with people who are post-op ACL, where let's say they're 4 months along, they've got their kind of range of motion and their MMT, but they're not from a performance standpoint where they want to be. And they're look, I can't really see you more than 1 or 2 times a month. It's forced me to figure out all right, well, under these constraints, can I still help this person? And sometimes necessity is the mother of innovation. I think that there's ways to provide value at low cost, with we have a YouTube channel, we have Excel spreadsheets with all the videos embedded into our programs. And so I can, it's not ideal, but I think I can see somebody, 1 or 2 times a month and do that from 4 to 10 months post-op. and do a pretty decent job. Again, not as well as I could if I saw them 3 days a week, but there's ways to do it. And I think that, with COVID, whether it's been like in education or in medicine, it's kind of forcing people to adapt a little bit more and not just rely on kind of, being on this insurance-based model and not being able to value people's time and money. And I think that, ultimately, like insurance, and there's reasons to take insurance because in our model, right, like we're kind of exclusive. There's certain people that we can't treat because of, the cost appears too high, even though we can make a case in the long term we save money. But it's kind of a deterrent to say, wow, I've got to pay this for one session. When in reality, they might pay more if they went to somebody in network. It would just be over the course of a few weeks. But with that insurance system, it almost like homogenizes care because everyone's getting the exact same reimbursement. They have the same business model. And I think that like, as much as, we want to like stick together as a profession because other people are throwing stones at us, I think competing is going to make us better too. And not relying on everybody getting compensated the same way. But because the system is so homogenized, like nobody really has any incentive to like, all right, like, well, what if we only had 10 sessions? What would we do? I think having those constraints and those pressure could make the system better, but a lot of people don't really want that because they're comfortable. So the point of this whole spiel is that it's complex because we like to vilify the insurance companies. And I think in certain cases they are the villain, but medical people are also responsible for the system and lobbies and all these different things. So it's really, really tricky. And again, we don't have the answers, but you do a great job in your course of raising a lot of these questions, and it's just really thought provoking. So it's a great resource. Any kind of parting thoughts? I know you've been really generous with your time before we kind of ask you about where people can learn more about you.
No, I just say that kind of like the running theme of the course and just kind of our discussion, just be comfortable with asking yourself questions and always being curious. And I always think that coming up with more questions is sometimes more valuable than coming up with answers because, I don't think that we always can have an answer for everything, and being comfortable with getting stuck in an issue and thinking about alternative pathways to solving that issue, I think is often much more valuable. Yeah.
And then where can people learn more about like your course, your resources, and the kind of work that you do online?
Yeah, so I have a website, it's NicoleSurdykAphysio.com. And from there you can kind of find everything I do. I have a blog. I have my Instagram and, social media channels, some YouTube videos. And then I have some ebooks as well on my website. One of them is free. It's just kind of my underlying principles of rehab and performance training, kind of what I go into each case thinking about. And then, my courses, I have the Ethical Return to Sport Decision Making course you can get to on my website. You can also get to it through Eric Mira's website, thesciencept.com. It's on his website as well, and I recommend his blog too. And then my other course is Managing the Uninjured Soccer Player, and it's all about the injuries that are common in soccer players, how to treat them, how to get them back to performance levels of soccer, and how to potentially reduce their risk of recurrence and primary intervention as well. So I was teaching that one in person. Obviously, I'm not right now, but I am going to be putting it online soon. I'm just kind of updating a couple things in it. The problem with the science-based field is it always updates, so you gotta always update the work. But yeah, that's about it.
Cool. Yeah. Thanks again for your time, and we'll post all those links in the notes. And again, I encourage people to check out all those resources. So thank you again, and enjoy the rest of your day.
Thanks so much.
All right. Thank you.
Thank you for listening to the Resilient Performance Podcast. As a thank you for listening, we'd like to offer a 10% discount on our online products, which you can find at resilientperformance.com. We'd like you to use the promo code PODCAST, PODCAST, to get the 10% off. Right now we have the Resilient Movement Foundations course online format for you to purchase there. And we hope to grow that soon before the end of the year and have some other offerings. We hope you enjoy. Again, that's promo code PODCAST
PODCAST for 10% off. Thanks.